Want me to show you PowerPoint? You want me to show you a PowerPoint?
Sir, definite. Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today I have this great opportunity. Professor Jacques Himpens, he's also with us from Belgium. He's a mentor of mentors and pioneer of bariatric surgery. So this is great opportunity for myself as well as my viewers, for all of you, to know more about Gerd after sleeve gastrectomy and how can we deal. As you know, this is our sixth interview series that going on. And in my opinion, so this is the best time to know more about Gerd after sleeve and how can we treat. And as well as this is great opportunity for all of us because Professor Himpens is live with us. If you see, we compare with webinar. In webinar, such a great surgeon have only 10 to 15 minutes, then you cannot explain what you want to say. But now we have a lot of time. Professor will demonstrate his technique, and as well as you can ask question. We are live on global laparoscopy, and you can ask any question. And just now I can see many of our surgeons, they are live with us. Professor, so much thanks. Really appreciable. Always you support us, support knowledge, sharing knowledge, and so much thank. Sir, please, over to you.
Thank you. I would like to share my screen. I'm not sure.
Sir, yes. Please, sir.
Yeah, I'll try to do that, but it's not lighting up. Hang on. I don't seem to be able to share my screen.
Sir, please. You have access, you can.
Yeah, I have access here. Oh, here it lights up now. Okay. You got it?
And not yet, sir. So just, yes, I can see.
You can see it now?
Yeah.
Okay. You get it?
Yes, sir.
Okay. This is a talk that I gave about a year ago for Bariatric for my friend Bruno Dillemans. And I did some extended research at the time. So if you allow me, I'll just repeat. I'll change it a little bit, and I'll just repeat what I said then, because I think it pretty much wraps up the subject. As you very well mentioned, when we perform bariatric surgery, and especially sleeve gastrectomies, we are often faced with the issue of Gerd post-operatively. There's actually a very good paper that was published just a month ago in Obesity Surgery, where they compared the outcome after sleeve versus Roux-en-Y gastric bypass in patients suffering from Gerd preoperatively. And the conclusion was that we have about double more incidence of increased Gerd after sleeve than after Roux-en-Y gastric bypass. So one of the options with Gerd after sleeve would be to convert, of course, to Roux-en-Y gastric bypass. But first, some patients will refuse that. Second, some surgeons will probably not be very keen on doing this. And three, the conversion of sleeve to Roux-en-Y gastric bypass has its morbidity, and it's not 100% foolproof procedure either. So what I would like to show you is what we started doing quite often now in sleeve gastrectomies that would develop Gerd, and even OAGBs developing Gerd, and even Roux-en-Y gastric bypass developing Gerd. So what the technique that I will briefly describe to you is the round ligaments of the liver that we use as a reinforcement for a hiatal hernia repair, or for just strengthening the hiatus, even in case of absence of a hiatal hernia. Now, I will briefly show you the story of one patient, a patient who was 51 years old and who actually had been treated 10 years ago with a BMI of 45, having a small hiatal hernia, esophagitis grade C, and who had been treated back then by a Roux-en-Y gastric bypass. She was put on PPIs for years, twice a day, which is the maximum dosage, at least in our country here, and really didn't bring us much benefit. And when we look at the evolution, if you on that little screen in the middle, you see that the progression of the weight was not ideal. And starting from 63 kilograms, and I repeat, she weighed 121 before the Roux-en-Y in 2014. But as years went on, you see that she actually started gaining some weight, and up to 94 kilograms. And the bad thing was that she was suffering from persisting Gerd. She had all kinds of nutritional consultations. She was put on, as I said, double PPI dosage, but nothing really helped. And so we decided to go ahead and take her to the OR to perform the hiatal hernia repair, and also to do something, an additional procedure to prevent recurrence and to benefit the patient in terms of Gerd. Now, what we do in redo surgery, be it the Roux-en-Y or an OHGB or a sleeve, we always do a 3D reconstruction. And you see here, this is a dynamics, and you see you can turn around the part that's of interest here, which is the little gastric pouch. And when we look at more in detail, we see that the gastric pouch has a total volume of 48 cubic centimeters, and that there is a clear marking here of the incisura created by the hiatus. So there is a small hiatal hernia that was measured at 10 cc's, and also a 38 cc's gastric pouch. Okay, so this is the repeating. And in terms of blood work, she had an increased cholesterol, low vitamin D, normal PTH though, and she was on the edge of becoming diabetic. So I think it was time to take her to the OR. And we decided to address two things. First, Gerd, and second, the weight regain. The weight regain, but it is not the subject today, is the placement of a phobia ring, a minimizer, but we will not focus on that. We will focus on the treatment of Gerd, on the hiatal hernia, that we did address by performing an hiatoplasty and doing a reinforcement with the round ligament of the liver. This is a brief video of the procedure. This is my hospital, the Delta Hospital in Brussels. And you see this patient, as I said, had a Roux-en-Y gastric bypass. We start the procedure by freeing. There's very few adhesions, but we want to free the hiatus because we need to treat that small hiatal hernia that we diagnosed with the 3D reconstruction. This is the initial dissection. We see here the dissection of the gastric pouch. that is being freed from the right crust. Here we lift the gastric pouch and we create what we call the dorsal window. Then we go to the left of the patient, and here we will separate the pouch, which is here, from the remnant, which is here. And you see here the staples. So we separate the gastric pouch from the remnants. You just saw the left gastric. Here again, we continue separating the gastric pouch, which is here, from the remnant, which is here. And you see now we create a nice separation of both. Once we have the separation from the remnant, which is here, and the gastric pouch, which is here, we continue freeing now the hiatus by freeing the left crust. And eventually we can lift the vagus. This is the wide opening that we have in the hiatus. We close this, or we tighten at least the opening by doing the Rosenthal technique, which is the use of barbed wire, non-resorbable. We usually create a figure of 8 stitch and make sure that it's not too tight. So as we will tighten the knot, we will make sure that the tube can still pass. That is advanced by the anesthesiologist. Please note that we left the needle in place. Now we move to the left of the patient. We look from up downwards. Here is the umbilicus, and here is the round ligament and the tissue, the fatty tissue around the round ligament. When we free this, we go from distal to proximal, and we have to stick to the parietal wall, to the parietal peritoneum, to make sure that we will not create ischemia of what we will need to use for our plasty. So dissecting from distal to proximal, you see here, we stay to very close to the parietal peritoneum. Here we get to the falciform ligament, which is here, and we're still free the round ligament. Here we go. This is the falciform that we need to free because we want to make sure that we will have sufficient slack to switch the round ligament of the liver from right to left. Here is the round ligament that we see very clearly, and that is now almost completely freed. And don't forget, the distal part has been transected. So now we can, as you see, we have a very bulky part that we can flip around the proximal part of the gastric pouch using the opening that we created while we dissected the hiatus. And you see that there's no traction whatsoever. And then we flip all that tissue, making sure that we don't twist it. We flip it around the proximal gastric pouch. Remember, we closed the hiatus. We still left the needle in place, and we will use this to fix or to fixate the round ligament that we have now placed to the left of the patient. And here you see we first do perform a stitch in the proximal part, uniting the hiatal repair to the proximal part of the right end of the round ligament. Then we will place a second stitch, this time on the inferior part of the round ligament, but again united it with the hiatal repair. So we have a stitch on the right side, and now we go to the left side. What you see here is the minimizer, but again, I will not focus on that. But here you see that we will use a third stitch to fixate the bulky round ligament to the left cruce here, the upper part of the left cruce. Here we go. And then we will use the remaining part to fixate that to the right cruce, the upper part of the right cruce, so that we create a total circle around the upper part of the gastric pouch. I remind you, this is a Roux-en-Y construction. Here is the minimizer that we placed because of the weight regain, and this is the treatment of the reflux. And this is at the end of the procedure. We advance the tube, or we ask the anesthesiologist to advance the tube, make sure that it passes very without any resistance, and also across that minimizer. So this is the procedure. What we have to know is a few theoretical things. First, we have to know that in an adult, the ligament is supplied by one set of vessels, which is arterial, coming from the hepatic artery. Venous comes from distal and creates the superficial epigastric veins and its arboration. So we make sure that when we transect distally, we will not create ischemia. Now, to make sure that we didn't create ischemia, it is an accepted technique to use ICG, Indocyan in green, to ascertain the viability of the tissues and of the ligament. There's a paper on that was published in 2021 by Asti in the Journal of Laparoendoscopic and Advanced Surgical Techniques on 18 patients with a short follow-up, but with no recurrent hernia, with the technique that we just described. The best paper that I found is in Langenbach's Archives of Surgery, published in 2021. And I recommend this for you to read. It is the applications of the hepatic round ligament and falciform ligament as a flap and graft in abdominal surgery in cases of Gerd to reinforce the hyatoplasty. And here you see the several options. Here is what we did. Freeing the round ligament, closure of the hiatus, and then wrap the round ligament that has been freed around the proximal part of the gastric pouch, which can be the proximal part of the sleeve, of course, if previously you performed the sleeve, and to make sure that you get a reinforcement without any foreign tissue. You can also use the round ligament as a sort of a necktie that you wrap around the gastroesophageal junction, just like you would do with the Nissen. And moreover, you can wrap anteriorly, preferably, the pouch to the distal esophagus. Finally, there is the even possibility of using this technique for covering a perforated ulcer, for instance. So that's three different ways of using the round ligament flap. Now, the paper with the largest experience comes from France. It's unfortunately in French, and it comes from Palou and colleagues. It's about 100 cases, and you see that with a short follow-up, 4-year follow-up, we see that there's a close to 100% success rate with the use of again, this round ligament of the liver for the treatment of gastroesophageal reflux. This operation in this indication, just for treatment of reflux in primary cases, is called the Rampal-Marshall procedure. Was published in 1967, but first was mentioned in the late 1800s. Another, I would say, very known surgeon that used this technique is Roger Jacob in France as well in the years 1950. And the technique is commonly used in Brazil by Goes Lopes, who published on that as well. Now, in our particular patient, we see that after a few weeks, her weight went down again, her esophagitis went down from C to A, and she was capable of stopping the PPIs that she had been taking for years. Short discussion, the round ligament reinforced hiatal hernia is useful, I think, because it makes you avoid, or allows you to avoid, synthetic material. You know that when you do a reinforcement of a hiatal repair with synthetic material, there is a big danger of creating erosion of that material into the esophagus, into the proximal stomach. You can use this technique, and that's very interesting, I would say, with bariatric procedures, as you saw here. But the most, I think, the most relevant indication is this one, published by Runkel in 2020 in obesity surgery, and it is the prevention of intrathoracic migration in bariatric procedures, and especially in sleeve gastrectomy. You know that migration into the chest in sleeve gastrectomy is a real danger. It's an existing issue. And if at the end of performing a sleeve, whenever, especially when you see that there is some traction, I think it's a good technique to use to wrap the round ligament around the gastroesophageal ligament, around the gastroesophageal junction, I'm sorry, to avoid that migration into the chest. So to conclude, I would say, I'm not saying this is the best technique to avoid reflux, but I think the best indication is this one. It's preventing the intrathoracic migration in bariatric procedures. The paper I mentioned by Runkel and colleagues shows a 93% success rate, even though the follow-up is kind of short, maximum of 3 years. But still, I think it's a useful trick to have in your armamentarium as a bariatric surgeon. Thank you.
Sir, excellent demonstration. So you can click stop sharing.
Here we go.
Yeah. Sir, excellent demonstration. I was witness in Bruges, if you remember, then had you perform as well their deferred live in the session of deferred live. Sir,
I remember that.
Yeah, my question, have you also experience of cardiopexy in sleeve gastrectomy as well?
Yes, absolutely. Absolutely, that's what I tried to say. But especially in revisional procedures. We don't have experience with the use of that technique in primary procedures, but in revisional procedures, especially when you have a migration into the chest, I think it's a useful procedure.
Excellent, because as till this time, so what was we thinking in case of migration or Gerd after a sleeve, we always go for definite, we reduce the sleeve, we repair, we do heteroplasty and go for Roux-en-Y gastric bypass. So as you mentioned, it's much simpler as compared to Roux-en-Y gastric bypass, and also anatomical. So same anatomy remain, and sometime patient is not interested to go for Roux-en-Y gastric bypass, and then maybe the surgeon ability, as you have mentioned, But it's amazing. Sir, just a question: how many cases in number till this time you have performed? So Gerd after a sleeve and then cardiopexy with the teres ligament.
Yeah, I think I don't have the exact number on the top of my head, but whenever, I mean, we used to systematically convert a sleeve in rheumatoid gastric bypass when we had the reflux. But the problem is, on the long term, when you look at the outcomes, it's far from a foolproof procedure. And in many cases, we will have either poor outcomes in terms of reflux, or we can have marked dysphagia in rheumatoid gastric bypass. And so we started doing the ligamentum hepatis plexy in cases since, I would say, 5 years ago. And I must say that perhaps, and again, I don't have the exact figures, but I think, in my opinion, it's worth doing, especially when you have the slightest contraindication to perform a rheumatoid gastric bypass.
Of course. Sir, also you mentioned a paper, I think the name was Marshall, and also you mentioned a Brazilian initial treatment of reflux that routinely we are doing fundoplication in non-obese patients. That is the routine treatment. So what is your opinion? Then why we are doing fundoplication in such a case? Can we go with this teres cardiopexy?
It was described initially like that in the late 1800s, yes, and it was published in 1967.
So I understand, but nowadays, why it is not in our routine practice? Nowadays, if such a case we are going to do for fundoplication, Nissen or Torre or any type. So what happened? What, because definitely you can explain about this. Why this evolution from teres Pexy to fundoplication?
Well, it's actually a combination of the two. The initial description was actually, I can show it now, of course, but the initial description was actually the combination of both, but the combination of the ligamentum teres pexy and 180 degrees fundoplication. Not even a toupee, but 180 degrees. So, which in their opinion, the French opinion, was that it would recreate the angulation of the esogastric junction, which would indeed benefit in the treatment of the reflux. So initially, it was described as a combination of two. More recently, it has been used in bariatric surgery, because in the initial description, it had nothing to do with weight loss surgery.
Sir, exact. So regarding, sir, the reason or etiology of GERD after bariatric, especially after Roux-en-Y gastric bypass, as I remember in your previous interview, when I interviewed, one of the reason was so parietal cell, as you mentioned in that interview, I remember. So because sometimes we do all of these things, but again, we are facing GERD till after Roux-en-Y gastric bypass. And at that time, we also discuss about vagotomy. So truncal vagotomy, I remember at that time also we touch about this. How is it effective or not? So how can we reduce the acid production? Then maybe we can take, are you agree we can combine truncal vagotomy with this anatomical changes?
Sure. And actually, I don't know if you're familiar with that, but whenever we do the Roux-en-Y gastric bypass and transect the gastric pouch, I systematically will sacrifice the vagus nerve, which means I will no longer try to dissect between la trachea and the gastric wall, but I will open the pars flaccida and go right across, which will sacrifice, obviously, the vagus nerve. When you do the vertical transection, you have to make it very narrow, a pouch, to make sure that, again, you limit or you sacrifice the maximum of vagal branches. So what you get is a smaller pouch. So, of course, fewer parietal cells, but also a more radical vagal vagotomy.
Yeah. Sir, regarding
I'm sorry about my voice.
No, sir. Thank you. Sir, regarding OAGB, so my main practice is also OAGB, and that the reality patient are suffering with GERD. That is the reality. Till my pouch is below calf foot, my first stapler is there. I have a longer pouch, everything side to side. And they add that hypothesis, so anti-reflux, everything I am doing, that is not end to side. Again, some patients, they are suffering with this phenomena that is really also bothering the patient and also affect the quality of life. So can we go initially for in all, not all cases, but selected cases, if we see a patient has little symptoms of GERD before surgery, but there is no esophagitis type C or type B or type C, just type A, and then can we go initially for such a case for the protection or prevention, as you mentioned earlier, also prevention of sleeve migration is also good with this procedure. Just my question regarding first OAGB, then also for sleeve gastrectomy, can we go initially in both of these surgeries as a prevention?
It's an excellent question. And my honest answer is I don't know. In the initial, when I started doing OAGB, that was in 2007, I systematically used the remnants in OAGB. I systematically used the remnant and wrapped it around the G junction, like a Nissen.
I understand. Yeah.
And I know that many people started doing this now. The problem with that technique, though, is that after a few years, because of the fact that it is not a Nissen, it has a totally different mechanism. It's a sling that you create. The problem is that as years go by, patient loses weight, and also you get some ischemic changes, I'm sure, and then you get the tendency of creating a stenosis. And most people who had this type of procedure, sometimes 4 years, sometimes 5 years, or even later after the procedure, start complaining of dysphagia. And that is systematically so. And that's why, I must say, for the past 4 or 5 years, I no longer do that procedure anymore.
Sir, yeah. So regarding this Teres cardiopexy, so can we go? Yes, that fundoplication I understand, because some of a surgeon I also witnessed, especially in Central Asian state, one of the surgeons still he is doing. Yeah, same procedure. So OAGB, then fundoplication with remnant, still he's doing. I was there in Uzbekistan last year, Tashkent, and now also next month again I will be there in Tashkent, and also I will demonstrate there a OAGB case, and also at that time I was also witness, and we have talked about this. So how is it effective? But as you mentioned, so you started this fundoplication with remnant of stomach in OAGB that was no more effective. But what about cardiopexy with this ligament teres? Or you think it will be effective?
I think it's I mean, when you think about it, the principle is the same. You create a sling, but I think it is the advantage compared to the use of the remnant as a fundoplication, is you can create a sling that's much that you make as tight as you want. When you use the remnant, you always have to be very careful, because don't forget, you transect it. So you have to be sure that you don't create ischemia. With the ligamentum teres, you will not create it. And you can, as I said, you can really make it as floppy as you want.
Doctor.
Sure, sir. Professor Lauren Layani is also live with us. Professor Lauren Layani, we are talking about prevention of sleeve migration and also this cardiopexy with ligament teres. Any comment, any question from Professor?
Can you hear me?
Yeah, I can hear you, but I cannot see you.
Yes, Laurent.
Just give me 1 second. You can see my face.
Oh, no.
You are on
Oh,
bike or
no.
at home? It's good. It's good you are not at bike.
No. I mean, Jacques, he's a guru for us, so it would be very difficult to challenge him. I never, first of all, I never used the ligament teres to treat reflux after a sleeve. I believe, frankly, that when you see patient which has a lot of problems with reflux, most of the time the sleeve has migrated in the chest, and sometimes the sleeve has not been done properly. So I actually don't believe to just repair. I just basically convert the sleeve to an OHGB or a rural-gastric bypass. But to use as a prevention, as a routine, means like you do a sleeve and you put a sling as well, like the guy is doing sleeve plus a ring plus minimizer, for example. No, I never use it. And I mean, I feel it's a bit like, to be honest, it's like a piece of piece of fat. I just don't know. I know what Jacques is saying, and you can tight as well as you like. You don't want to be. I don't. I never use it, basically.
Yeah, but it's I don't agree, Laurent. I mean, it maybe it looks it needs to look fatty, because you need to preserve all the tissue around it, because otherwise you're gonna make it ischemic. But I can assure you that this stuff is tight and it's very much alive. And when you have to do a revision for a gallbladder, for instance, years after the procedure, and you go and have a look, you will see that that material is very much alive, believe me.
But Jacques, the problem, I'm sorry to take your time, but the problem is I cannot see the indication for during a sleeve revision, because if the sleeve has causing you so much problems, I think you need to change the sleeve to something else.
As I said, that's what we used to systematically do it, and we still,
As a primary.
No, I mean in as a revisional case, when we have reflux after sleeve, it's fine to do a gastric bypass, but often the patient refuses it, or you may have technical issues that prevent you from doing it. And so in that case, I think it's really acceptable to do a proper dissection of the sleeve in the mediastinum, bring it down, close the hiatus, and reinforce it with that ligament.
Okay, fair enough. Fair enough. I accept this.
So, Professor, just a highlight, because sometimes we are facing such a situation, as Professor Himpens mentioned, because patient is also using NSAID and patient must use NSAIDs, and also you cannot go for gastrojejunostomy, any type of gastrojejunostomy, because there is more chance of marginal ulcer as well as if patient is female and already is suffering with osteoporosis, some limitation. This is not a contraindication to go far, but we are so little because patient of BMI is okay, BMI is in normal range, just suffering with GERD, and so this is a good option. So now we have another option, because before this always we were thinking about this. Just imagine patient is smoker, and so we cannot go for any type of gastrojejunostomy or gastroileal because there is more chance of marginal ulcer, and because already patient is suffering with GERD, we cannot go for SADI in such a situation because sleeve is still there. We have the issue with the sleeve. Now we have another option, and with the recommendation of professor, and he has experience, in my opinion, as also I request from Laurent as well, and those who are also a pioneer of bariatric surgery, you must think about this, because nowadays, really the most common bariatric surgery at globe is a sleeve. There is no doubt sleeve is a good surgery. Sleeve is a more physiologic, that we must be honest. We are scientists. We must be realistic. So, but the main issue is GERD. Yes, this is the issue. Quality of life. How can we solve? How can we prevent? How can we prevent the migration? We must. Can we do omentopexy? Can we do the fixation of the angle of that incisor angularis with the part of anterior fascia of pancreas? Is it effective? Can we go for hyatoplasty? Can we go for cardiopexy with the teres ligament? So we must talk, we must think. This is my just humble question and request.
Well, as I mentioned briefly in my talk, there's an excellent paper by Runkel, and that was published in, I think, in 2020 in obesity surgery, and it describes, it's a meta-analysis that gives you all the details and all the indications of that procedure, and he has done more publications on the topic. And I must say, I would recommend you to read that paper. It gives you pretty much an overview of all the indications of that procedure and also the rationale behind it.
Laurent.
Well, you know, I tell you what I do. It doesn't mean it is what you should do, but it works very well. Is I believe these patients, the problem is anatomical problem. So most of these patients with GERD, with severe and bad reflux after sleeve, most of the time it's an anatomical problem, means the sleeve has migrated and the sleeve is most of the time distorted, maybe like a champagne bottle, little bit big here, little bit not really right. So I think the best, as is been said before, is to correct the anatomy. And what I do is I correct the anatomy. I go, I repair, I put the sleeve down, I repair, and I all the time now converted with or without resleeving. I convert this to an OHGB. And it does work very well, because I believe the sleeve, I mean, it has to be changed to another type of operation. Now, I respect what Jacques is saying. Sometimes maybe it's true. Some patient will say, "Doctor, there's no way I want you to do a bypass to me." My experience of doing only the diaphragmatic repair, repositioning of the sleeve with or without resleeving, which I don't like, thinking to treat the GERD has failed in my hand. All of them means it doesn't work. So if Jacques said, then adding this ligament teres around help much better, maybe.
Laurent, but my concern now, as you mentioned, if patient is suffering with severe GERD after a sleeve, there is some anatomical issue, maybe distortion, maybe little twist. How can we go for OAGB? Because when we will go for OAGB, again, we are distal to that anatomical issue.
Because Imran, if you have repaired the diaphragm, you have repositioned, you have recreated a proper, very long. Because when you convert a sleeve to an OAGB, you're going to have the longest gastric tube you ever have, because you cannot achieve as that long when you do a primary OAGB because of the angle. And so you have a very, very long, and believe me, the patient has no problem. In fact, they cure from the reflux problem. And then obviously you have the problem of the reflux, as well as if the patient is also still morbidly obese. This is two type of patient, and unfortunately they often have the both problem. So I think I do this. I have presented these patients numbers sleeve to specifically for reflux. Probably I didn't sort of separated them with weight regain, but this is what I do, except if the patient endoscopically has Barrett's esophagus, which is actually very rare. But saying this, from my own personal patients, which I operated since now 9 years, I am in UAE, this reoperation specifically for reflux after a sleeve, it's very rare, Imran. It's not a common problem. Maybe it's a problem we used to be, or on my own patient, I recorded. The problem is you never know if you have operated, if your patient has not been operated elsewhere, which is true. But it's not a common problem.
Now, Lauren, just a scenario, if patient is suffering with Gerd after a sleeve gastrectomy, there is no weight regain, but due to some relative contraindication of any type of gastric bypass, you cannot do just OAGB, or you cannot go for Roux-en-Y gastric bypass.
No, I will do that. I will do that. I will try.
Sir, just sometime we are facing such a situation. A patient is suffering with such a disease like just IBD. So maybe you are little worried. So you will not go for gastrojejunostomy. You cannot go. So now patient, we have such a case. Yes, rare. I agree with you. This is not common situation. But what will you do at that such a situation? Or you will repair only hyatoplasty, because you cannot go for gastrojejunostomy. You cannot attach any type of small.
The problem, Imran, is I have tried this even when I was in Australia, when I was a younger surgeon, and most of the time this repair, even if he look fantastic, has failed. I think Jacques probably will agree with that. It's fell in my hand.
Yeah. Professor Himpens, any comment, sir?
Yeah, well, you know what? Maybe I'll switch to the debate a little bit. I think one thing that it probably has been neglected too much is the motility of the esophagus. And I think I've seen patients, and I'm sure you all have, in whom, for instance, after a sleeve that you converted to a gastric bypass, the reflux issue was not solved. Okay. And why is that? That is because the problem is higher up. It's in the esophagus. And
it's true.
That's right. So I think that's something that you need to investigate before you take, especially in difficult cases or in, second revisions. You must make sure that you have an esophagus that's not like a sock, it's something that propulses the food downwards. And I think when you do the workup in a patient who has reflux after a sleeve or even after a bypass for the same indication, I think you must do a manometry. You must do a high-resolution manometry.
You remind me, Jacques, when I used to when I used to convert all my band in the year 2001 and
Yeah.
2 or 3, all the band I used to do and George Fielding used to do in Brisbane, and after he retired, and we have thousands of bands we have running around, and I was probably naive, and I converted band to sleeve on the 2-stage situation, or very rarely one, but I have no specific high risk, high leak, but I can tell you then the reflux after this sleeve was very bad. And why I say this is because this band patient has motility disorder. They have completely
Induced by the
destroyed,
band,
they have destroyed the esophagus. The esophagus is not pumping anymore. And this is where I find, I remember before I left Australia, I did about 325 sleeve, band to sleeve, and the result was very bad.
Definitely. Restrictive to restrictive, I agree.
I totally agree.
This is why now when we don't see band very much, but when I see a patient which need a band conversion, I convert it to an OHGB, and I don't mind if the guy will do a Roux bypass, whatever. But I don't think band to sleeve it's a good idea because of what you say.
Yeah, absolutely agree this. So, sir, Himpen, just because Laurent now he's with us. For our viewers, who is the good candidate for Teres Ligamentopexy? Who is the good candidate?
Well, I think anybody who has a hiatal hernia of significance, and I'm talking about the diastasis of the hiatal cruray, where you close the cruray with some tension, I think it's good to reinforce it. And I must say, I systematically do it. And I think that's probably the best indication. Another indication would be the revisional surgery, where somebody has already been fiddling around on the hiatus, and you don't have an immaculate hiatus. Then I think use your own tissue to reinforce is always a good idea. So to answer your question, one, the hiatal hernias where you have a big gap at the hiatus, and two, or any revisional procedure where there has been a hiatal dissection previously.
And maybe I missed the beginning of your talk. Just for a technical point of view, do you, after you go around, you mobilize it and you pass around, do you tie this over the bougie?
Yeah.
And then how many stitches do you put? 2, 3?
4.
4. So you go up and down with 4 interrupted stitches.
I close the hiatus, and I leave the stitch with the needle. I wrap around the ligament around the gastroesophageal junction, if you will, and then I fix that. I use the needle that I used for the hiatal repair, and then I place 3 additional cardinal points so that the entire surface is covered.
And is used non-absorbable?
Non-absorbable.
And also fix with the right corura as well.
And do you put this on the esophagus, or around at the level of the OJ junction, or more on the upper stomach?
Just like a Nissen, a little bit.
You take both. You take both.
Yeah.
Okay, I got it.
Yeah.
Yeah, fair enough. So you need to dissect the ligament quite fat.
Sure, absolutely. You need to have a really bulky thing.
A good piece of meat.
Yeah. Yeah.
Okay, no, a good piece of fat. I understand.
Yeah.
Thank you.
Sir, so much thanks. Really, it was again a great opportunity for myself and for my viewers. And sir, special thanks. Really, you, Professor Laurent, always you are sportive. And this is our a little just a step for sharing knowledge. GLR platform is for especially those who are youngsters and they like to go for weight loss surgery. And nowadays, obesity is a real pandemic and metabolic syndrome as well. But unfortunately, they are also facing such side effects or complication after bariatric surgery. And one of them is Gerd after a sleeve. And one of the options that you mentioned is easier. And in just my humble opinion, it's much better than links. Links is a foreign body and definite it will be. Are you agree, sir? It must be better than links.
Absolutely, absolutely. It's a foreign body, and with foreign bodies, you always run into trouble sooner or later.
Yeah, and definitely it is more natural, more physiologic. Laurent, have you any comment, or we can close our session?
It remains.
Listen, I came a little bit late, but no, I agree. I have done so many bands in my life that I will not. I am totally against the link put in the foreign body around the esophagus. I mean, one day is going to be going inside the esophagus, and it's a hell to fix. So I think Jacques has even more experience, probably surgical experience, but I don't do any of this at all. So using your own ligament has a value. I'm going to try. I will tell you after that.
But don't forget, you need to have a bulky.
I got it. I got it. I will do that.
Stay close to the abdominal wall.
To the abdominal wall.
Yeah.
Yeah, I got it. Thank you so much.
And when you do the dissection, because you probably did the initial procedure between the legs of the patient, when you start dissecting the round ligament, go to the left of the patient so you have an excellent view and start at the umbilicus, very distal.
Well, Jacques, I operate on the left anyway and never between the legs because I'm a left-handed and I operate like the Brisbane style, which I've learned in '98. So it will be no problem for me.
All right. But start at the umbilicus, okay?
Yeah, very far down.
Yeah. Sir, so much thanks, really, and it's a great honor. So two legends of bariatric surgery were with us, and my viewers, these all sessions are due to your attention. You must follow our interview series, and if you have any question, you can ask in your comment, and Professor will answer. Sir, again, so much thanks. And next week, same Tuesday, 10 p.m. Dubai time, we will be with another legendary bariatric surgeon. Sir, again, so much thanks and have a nice time.
Au revoir.
Au revoir.
Thank you. Thanks a lot, sir. Thank you.